Dr. Luvuyo Payeni, and Begeli Bege is always 1800 to 1900. We are here. As you know, that Dr. B Talks is a platform for us to be able to have conversations where we are free to share, whether as a healthcare worker or as a service provider or even as an experienced person in terms of being a patient or just an interested community or a citizen that has got an interest in healthcare. The platform is aimed at making sure that we create an environment where everyone is free, there are no boundaries, there are no walls. But importantly, it's what we refer to as an edutainment platform where we aim to ensure that we educate, we empower, but importantly, we give hope and make sure that people understand there are opportunities and there is healthcare services that must be rendered, as well as improving the health lifestyle. As we always say, we try and have a theme for the month, and this is March, and in South African context, this is a Human Rights Month. And we are ensuring that we try and stick to a theme that is in line with the celebrations of the month. You just would have seen us last week. We were concluding and reflecting on February, which was a Reproductive Health Month. So yes, we're here to kick off now a Human Rights Month. We promised you that today we're going to look at health access, as well as next week take you through to your concerns, your issues, and your experiences when it comes to the issues that relate to complaints management. So welcome, and it is exactly now 18:02, and please feel free to invite others, please feel free to share, but of course ensure that you post your comments on our comment section, and this is your show, and we would like you to ensure that you are as participative as possible, but importantly, we want to hear your views, we want to engage with yourselves and make sure that we meet your expectations halfway. We promised you, you saw the posters, you saw the adverts during the week, that we have got a guest, and not only a guest, I can give maybe that info and background that I also sometimes refer to him as my mentor when it comes especially to this platform of edutainment, especially using the platforms such as the social media as well as other digital platforms. And here I'm referring to none other than Dr. Fundi, who has agreed to grace us. He is a busy man. He is a busy man. But we're so grateful as Dr. B Talks that equally so he had managed to agree to be part of the show and spare some moments with us. And I don't think we could have asked for a better person for us to start and kick off the month because of his expertise, experience, especially when it comes to the issues of public health as well as health access. And as we converse, and you'll agree with me why do I say so and why we chose to start the month and launch. But of course, before we kick off and start, we cannot forget to announce and remind you that Dr. B Talks has been proud to have had an opportunity to have partnership with Sowetan, where the platform of Dr. B Talks is expected to even expand, where we will be using the Sowetan digital platforms as well as print media, where there is going to be a bi-weekly column which is called Ask Dr. B that will be available on Sowetan. So please ensure that you follow us on Dr. B Talks, you follow us on our platforms, and you continue to invite as many people to be part of this growth and this family. Welcome to Dr. B Talks family. And Dr. Nyati, thank you very much. And I'm sure even my viewers are like, hey, we are upgrading now. We're not going to be calling. We're not going to be saying, please, test one, test two. Can you join online? Instead, we are here. We are with you live. And I think, thank you very much for availing yourself, but not only yourself. Viewers, I wanted to welcome him first before I can share this part. He did not only agree to be part of the conversation, but he said, Mninawa, I see your growth. I see where you're going. Please come and tap into my resources. Let's see how we can feed and make sure that your viewers get the best out of today. And we are hosted in terms of physical venue by him, but also he has agreed to be humbly a guest. It's a funny one. A host and a guest and a guest and a host. But yes, this is who we are on Dr. B Talks. We break boundaries. We keep it just simple like that. So yeah, welcome to the show. And thank you very much once more. I am so humbled, and it's really an honor, both the time and the space that you have offered for us.
Thank you very much, Dr. B. I think like we've been talking for many years now. We've been talking about potential of collaborating because the agenda is the same. It's about informing the people of this country It's about discussing the issues that are, of interest to them, and just generally, making sure that we don't leave people behind.
Yeah, and I think, as you might have heard, viewers, in the main, it's about creating conversations that are going to be impacting, not only knowledge, but allowing an opportunity for people to express, to share, but also feel comfortable in having a safe space. And that's what Dr. B Talks is presenting, a safe space for us to be able to talk, converse, and talk about health issues and ensure that we can impact knowledge. We've got a lot to talk about.
Yes.
The topic is quite cumbersome.
Yes, it is a big topic.
And at some stage, I felt like, maybe our viewers will have to also be considerate with us, where we are going to be taking a bit of each item on the topic. But importantly for us, in any case, it's always just creating these awarenesses, creating the conversations. And please, if there is any area that you feel that we could have touched on, feel free to comment on the comment sections. And also you can leave your questions at the end of the show, and we'll make every effort to make sure that we respond to those. So please feel free to just share with us if there are areas of the topic we might not have touched. It will be definitely due to time issues, because we're talking about health access. We're talking about human rights. Both of those are issues that are really of concern to everyone. Not only people that are health activists, not only people that are health users, but in general, we talk about human rights. We know that on the 21st, there is commemoration of what they refer to as the Langa Massacre. By the way, I come from Utinek.
From the Eastern Cape.
Yes, I was going to say that there is Sharpeville. I choose to use Langa Massacre because it's Sugetinacha, and we also were participating there.
But you see, Doc, because you are going to be partnering with the Sowetan, which is more of a national newspaper, you're going to have to start from the back, with Sharpeville in 1960.
Yes,
and
yes,
then
before we came to Langa after.
Yes. 1985.
Yes, no, yes. So that's what we are commemorating on the 21st, the Human Rights Day, which we know that it's a very significant and a milestone in South African democracy, as well as the history of the country. So there's always an expectation from citizens ordinarily that, yes, they've been hopeful, they've been wishing, as well as being aspiring that as part of the human rights, there will be some development in terms of their lifestyle.
Yes.
And like you say, you share a history on that, and maybe as an entry point, you may also share what has been your observation, and maybe what your wishes are. I can't say expectations, because nowadays people say we've been having expectations, they are not being met. Maybe let's just be polite and say what becomes your wishes now when it comes to just issues of human rights in general, before we go to healthcare issues. Yes,
so I think luckily both of us spent some time in one way or the other at university, being forced to talk about some of these things, and somebody like you even much more active as a student activist, So, you will know that every year around March 21, in fact, on March 21, it used to be called Sharpeville Day or Langa Day, and...
there's nothing wrong with the generation. I know you are that generation, I'm this generation.
Yes, no, but I mean,
the history is the same.
For almost 32 years, there's been a commemoration, of Human Rights Day in South Africa, since 1994. So this is the 32nd year, but others will take it back to 85, of course. Take it back to 1960. I mean, we come from that history as a country whereby there was apartheid. And that was meant...
And that's our fiber, by the way.
Exactly.
It's not an offense. It's not anything.
Yes.
It's our fiber. It's our history. It's who we are. Yeah.
Exactly. And because of that, generally, people who were black historically and now African, Indian, colored were considered black. Those people didn't really enjoy human rights in this country. And therefore, that's why it's so important, I think, to dedicate the whole month, of March as a Human Rights Month. Because I often say to people, it's been 32 years, but if people understood how things were in 1994, there were different institutions that were responsible for health. There was in Transkei, there was Ciskai, there was Venda, there was Muputatswana, there was, so many
what we call homelands. There were Cape colonies.
Yes,
as well.
And then there were the colonies for Cape, Transvaal, Natal, and the Free State. So you had all of these, authorities who were all supposed to be looking at matters of health. And in 94, Minister Zuma, Nkosazana Zuma, had to bring all of these into one place. And different parts of the country were at different levels in terms of infrastructure and other things. And obviously those that were previously serving the white people of this country were more resourced. And the ones that were serving self-governing territories, and maybe the homelands, were the least resourced. And yet, when we put these things together to make sure that there is some standardization, and equity, it was not something that can easily be solved. And therefore, as we become critical, as we are going to be in this conversation, we must be mindful of the fact that we didn't start. The baseline was not the same.
I think that's what I was going to raise, to say, viewers, welcome for those that might have just joined. We are still with you at Dr. B Talks, and we are having our conversation as part of the Human Rights Month, which is access to healthcare. And as you joined, and as we have heard now from the guests, is that at the end of the day, we just need to have an understanding as to, before we talk about health access now, where do we come from? So the background, and please don't think we are politicking, no. It's just a question of necessary information, background, as well as the history that relates to the topic of the day. And it's about us, where we come from and how did we get to where we are. And as we would hear on the conversation as to, if we are to say what are the barriers, what are the issues that influence access, obviously your infrastructure will be amongst those, the access therefore in terms of the facilities and the makeup of the facilities. So that was just to get us tuned in, but thank you very much for joining. Please feel free to drop any comments on the comment sections. Continue to feel free to invite anyone and share the link as we are live on Dr. B Talks with our host, our guest, Dr. Nyati, presenting and coming here to share with us on the conversation on access to healthcare. Now let's get to the gist of the matter.
Yes.
I am from Etinach and I want to access care.
Yes.
Is it as easy as it sounds? What has been your observation? What has been, not only observation, because you have been an activist in terms of the healthcare space.
Yes.
Not only as a professional yourself, but having been an activist and being mindful of the realities of accessing care. What do we talk about when we say healthcare access?
All right, maybe let's take one step behind.
Yes.
Just to remind our people, there's that small book called the Constitution.
Oh yes.
Yes. And that book, which has got the Bill of Rights, and especially in chapter 2, there is section 27 that talks about right to health.
Yes.
I think that's where we should start. That right to health, or constitutional right to health, it promises access to quality, affordable, equitable healthcare to all South Africans.
Ithi xa ndizalwa nali ilungelo lam.
Nali ilungelo lakho, as far as impilo is concerned. There should be no problem in you accessing quality, affordable, equitable health services noba ukweyiphi corner of South Africa. That is the promise. But ke ngoku ke into esizoncokola ngayo ke, which is linked to the question, is ingaba
Sindaweni kule kanani?
Yes, how far are we in ensuring ukuba this promise of access to healthcare for everybody in South Africa is a reality? Now, the answer then, you were asking me about Etinaga. Luckily, when I started practicing medicine, I spent 5-6 years in the Port Elizabeth, Uitenhage area. Kwalanga, obviously, even those days, you had the public health system and you had the private health system. So I was a GP in the private health system, which will give a different answer to your question. But it is only the minority of people, who could access private health care, because most of them worked for VW and the component industries. But the average person in Kwalanga, Uitenhage, did not have a medical aid. Exactly. They had to find ways to access health care, and it was a challenge to get to provincial. I think it's called Uitenhage Provincial. It's lots of clinics between that people needed to use, and they be referred a provincial. But the provincial was not made for all races. It was made for a certain privileged group. And therefore, to everybody else, it was a challenge, because then this place is overcrowded, not enough nurses, not enough, doctors and all of those. I'm talking about those days.
Of course.
So an average person from the townships like Langa in Uitenhage, or any township in South Africa for that matter, those who are not privileged enough to be in the 16% of privileged people with medical aid, they struggle with a few things relating, to healthcare. The access issue, because ideally there should be a healthcare facility within a reasonable distance from where the people are. But it's not just about the availability of that, but also it must be functional. You can have a clinic. Yes, you can have a clinic, the white elephant. Okay. Or no, actually, ikona, bakona no nurse, bakona no trigger, but there isn't, all the necessary infrastructure, equipment, or even medicines, so it's not just about to access it, but once you are inside, there must be professionals who must make sure that they attend to your problem timeously.
So I get you to be reminding and maybe empowering us that even if it talks to the issues of access, it's not only about just getting there.
Yes.
You are saying that what is important and what is expected to happen is that it should be the whole food chain of saying, I came here and I'm living here.
Yes.
And what would have that meant for me?
Yes.
Did I get to be there? Did I get access to someone to help me? And did that person was that person able to actually comprehensively manage me, including me taking something out in a form of medication, or even a better of a referral to a better service, or in terms of the higher level.
Yes.
So access is not just about saying Nancy Kona and that's it.
So they talk about the key aspects of right to health. Accessibility is a one. Availability of services. Because, it's about the acceptability of the quality of service you are getting there. Because other people would say, no, I spent the whole day there and then I left with only Panado and whatever. So when people leave that facility, how happy are they about the experience? How professional? Were they attended to on time? Were they treated with dignity? Were they treated with respect? Did the nurse or the doctor take time to make sure Ukuti, their problem is explained? And if it cannot be attended to at that level, they are told, Ukuti, your problem needs the next level. Funeka you must go to Livingston
and well
or
articulated for that
Doraminza.
matter.
Yes, you know, if you are in PE, for example, if you are in Joburg, it can move from the clinical problem. It needs to be attended to Jabulani Hospital or to Bara. So it's important that that whole experience is an experience that makes you feel that I am being treated with care and dignity.
And that's what we want to empower people with today, to say, when we are reminding, and it's part of our, anyway, contribution to say, this is a Human Rights Month.
Yes.
People have got different ways. Like we
Yes.
said, we know the country and government, which we appreciate that on the 21st there is that commemoration.
Yes.
But as individuals and citizens, we can also identify different ways of commemorating this. And this is
Yes.
part of it.
Yes.
To say, let's empower people. Let's make our healthcare users to understand what do we mean when we say access, especially when it's in relation to the rights. So I think that's one thing to our viewers that we also want you to note as a take home, and please feel free to comment and share your views and opinions on the comment section at Dr. B Talks, as well as under Luvuyo Paeni page, so that at least we can be able to engage and share with your experience and interact with your views. Please feel free and invite as many people as you can. Now let's take it a step further. We've now empowered and shared. But equally so, we do note that there is something that others would say it's factors, it's impediments, it's influencers. No, not that one that is on socials. There are issues there. There are other state organs that are having problems with influencers.
Yeah.
No, we're not talking about that. So we're talking influence in terms of You've capacitated me now, Dr. Nyati. Tomorrow I want to have issues and I want to go access healthcare.
Yes.
You can't tell me that you think it's going to be as smooth. So what has been the observations? What's your understanding? What is real in terms of issues that affect access, and what has been brought to the attention, both whether it's formally so or it's issues, because you do know that we know that there's issues of human rights in the country, there's issues of OHSC, there's issues of Public Service Commission. So there are platforms that would rather be used to help and make understand that people get the access that they want. So what has been the observation on what is at our radar when it comes to those now?
Yeah, you know, when I accepted the invitation to be your guest, you know, the main thing for me was you are doing what all of us as health professionals should be doing, to be advocates for our patients, for the families in the communities, about the things that are important. And so this show has got an element of education. Like you said, it's edutainment. Now, from a right to health point of view, you know, every human being has a right to the highest attainable standard of physical and mental health. All right? So, njengoba sithetha nje ngempilo, sithetha ngempilo enyameni and sithetha ngempilo emphefumulweni. I think we must be clear about that. Now, the Constitution has said this is the ideal. Section 27(1) that talks about access for everybody, including your reproductive rights. Section 27(1) and 22, it puts that obligation on Urhulumente.
Provide.
Their right to health, it's your baby to make sure that everybody ayifumana. Then ke iyothetha nangemicimbi ye-emergency ukuthi akekho umuntu, no one should be turned back from receiving emergency care. Sawubuyela kuyo ke kulento, you know, in terms of just those three parts, because in the last few months, we've seen quite a number of political parties standing and chasing people away, those who cannot show South African citizenship. And some of those people need an emergency care. And so when we are therefore talking about what kind of issues have we come across that violate right to, to accessing care, one of those is now what is called medical xenophobia.
All right.
Medical xenophobia. So people who feel that they should access healthcare ahead of those people who don't have a South African citizenship. Whether these people are here as refugees, or what's the other term?
Permanent residents as well.
Yes,
And then
so
asylum seekers.
Asylum seekers. So the violations that we have started to be aware of in South Africa are violations relating to the fact that some within our society are actually feeling that if you are not a bona fide South African citizen, you should not get healthcare.
Well, I'm happy you're touching on that as well, because equally so, now the advantage is that, as my viewers know, I am employed by the National Department of Health.
Yes.
So it's something that has been coming quite often, and we've had a lot of parliamentary questions. But as also, I think from a media's point of view, the ministry has been vocal in terms of what is the position and the stance when it comes to that. And of course, the message has been clear that when it comes to the access, like you're saying, no one should be barred from accessing. Obviously, trying to also respect that when it comes to even the issues of the risks that are there, because me and you, especially, even if you are a healthcare worker, just from seeing someone walk into the facility, you can't diagnose from the eye.
Exactly.
So even if you could say that, no, these people have got, they understand, and exactly, you can't just from the naked eye. So the department has taken a bold stance on that and has been communicating widely. So I think it's also a good thing that you are raising to say, these are the influencers in terms of access currently.
Yes.
Worse off that even amongst the responses and the media statements from the department was that sometimes even a South African doesn't have documentation.
Yes.
So you can't say as to who is and who is not. But I'm sure there's other issues. I think you had mentioned, or we were saying that there's also these other government entities that are there to, I don't want to say watchdogs, but they have been there to empower. Yes. I think that's the most progressive word we can look into, that they can empower citizens to understand how exactly the issues of access to care is about.
Yes.
Let's reflect on that. I do note that my province of origin, Eastern Cape, this week was also having a visit from one of those entities in the form of the Human Rights Commission.
Yes.
And when I say Eastern Cape as a province, I mean the Department of Health.
Yes.
They were having a session that the Human Rights Commission has been having issues around one of the facilities and the complaints thereof. And in the main, it was issues that relate to access as well. So those are the entities that I think you might also have worked with or have come across. And I'm sure you can share a thing or two in terms of both what has been coming up, but also how to empower our people to say, how are they part of correcting, if we can use that word?
I'll give, I'll give an example of something. Okay, maybe let me also say to the viewers that I originally come from the Eastern Cape. So, but I mean, this show,
it's not about
just about our home province, but we will use examples from there or any other place. Now, let me give you an example of somebody who is in Mpumalanga, Mpumalanga, the province. If that person has got a lung problem that requires a lung specialist, right? That person in Nelspruit or Kapokweni, or even Witbank, Emalahleni, if they need to consult a lung specialist, they have to be referred to, the hospital that's here in Pretoria. What do you call it? It used to be called HF Vervoort.
Steve
Biko Academic Hospital.
Yes.
That shows how, my
No. I said there's nothing wrong with the generational gap.
Yeah. So, and with all the best efforts of the health system, public health system in Mpumalanga, they don't have not even one lung specialist, what we call a pulmonologist. So that person has to be sent, I'm talking about in the public health system.
Yes, of course.
That person must be sent to Pretoria, and obviously wait on a queue, before they can be attended to by the super specialists there. All right, that's just one example. So, because of a lack of a particular professional resource, that person
Expertise.
can't have access timeously for their specialized lung problem. Yeah, if you are in Lusikisiki, in the Eastern Cape, or Port St. John's, or Flagstaff, and there is a diagnosis of a cancer, all right? You may have to go through a period whereby, if they need to stage to say how far has this cancer gone, you must go to Cecilia Makiwane in East London, all right, where they will do the staging. Uguti, is it still within the cervix, or it has gone to the nearby organs, or it has gone to the rest of the body? The machines to do that, up until at least about a year or two ago, you had to go via Nelson Mandela Academic Hospital, transport, that's 1 day. And then again from Umtata to Cecilia Makiwan, another day. Then you get to be done those tests. It will take you basically 4 days to go back home, because these specialized equipment, you can only find them in that kind of center, Now, same goes when you have to get treatments like radiotherapy, kuchiswe le
So
So again, it's an access issue. Why? Because there isn't, a fair distribution of the equipment needed across the province. So I'm just using those as examples.
I think before Nango up, one of our viewers, thank you very much for joining. There's a comment there. It is from Ntando, who is saying a great topic indeed. Access to care is one of those issues that talks to other departments as well.
Yes.
An example made here is that a clinic might be in close proximity, but be rendered inaccessible by the bad terrain. Recently in the Eastern Cape, viewers, yes, it just happens that we have got fresh memories and issues from Eastern Cape, but we still remain a national topic and relevant. So recently in Eastern Cape, we had floods washing away rural makeshift bridges and roads. People were cut off from schools, healthcare, as well as towns for days.
Yes.
And that's what she is also emphasizing, that when it comes to issues of access, I think earlier on I said, let's remind and let's empower, let's take through our audience in terms of what influences, what are the issues that are real. I think at some stage we do come across a lot when it comes to the term or the phrase of social determinants of health.
Yes.
And I think that's what Ndano is also
talking about.
So maybe you can also maybe come in when it comes to that. Yeah.
So you can have access to the best health facility, because by the way, there is the belief that public health system is all in trouble, but there are pockets of excellence in different parts of the country.
Yes.
All right. But obviously, the news that tend to capture the attention is where there's failure of delivery for many reasons. Now, when you look at matters of health, you can't look at them in isolation. You must also look, because you can't get optimal health if there's issues of, drinking water that is unsafe.
Okay.
If there's issue of poor sanitation, if there's issues of, housing. Abantu bahlala ematyotyombeni, ematyotyombeni, for those who don't understand, it's informal settlements. There's issues, of like we talked about the road infrastructure.
Yes.
Where people cannot go across to the next village that has got a clinic because the floods, they removed, the road, the makeshift bridge that was there. So water, sanitation, housing, education, all of those things, if they are not addressed, you are unlikely to get optimal health.
Okay.
And therefore, when we talk about right to health, it can never be attained if those other social determinants are not addressed.
It's not in isolation.
And therefore, government, and you come from government, they will talk about whole of what's it called?
IGR, intergovernment relations.
Yes, basically all the relevant departments must work hand in hand to solve these social determinants, so that when that person who comes from a particular village, I mean, sometimes abantu bahanjiswa ngekiriva, a wheelbarrow, to move a person from one village to the other, and maybe that mama is in labor, but the ambulance cannot come, so the ambulance must go and stop at a particular place, and then wheelbarrows must be used to bring that person next to where the ambulance is going to stop, or the sledges, abanye batsalwa ngezilei, babekwe phezu kwesilei uba umuntu, they must move to where the ambulance can go furthest. So all of those, it can, therefore that person, for them to access health, that road infrastructure,
there are those other issues.
Yes. Okay, I'm also gonna just poke you a bit. In one of the interviews we had during COVID, you were my guest, and we were talking about those scooter ambulances, but I'm not sure if we need to talk about them now. But I was just we were trying to solve that problem
of getting to there
in an economic way.
Yes.
But unfortunately, there were other matters outside of you that complicated that. But all you were trying to do is to say, let's use whatever is available to make sure that when people do need to access healthcare, let's look within our means and let's see what we can be able to do. But that was complicated, and there are other things.
So I think maybe on that note, there's a message that I'm picking up, which is twofold.
Yes.
One is to the healthcare providers, that we see you, and we appreciate that when you are doing your work, you still want to do your best.
Yes.
However, we are here to say we stand with you to remind, educate, and create an awareness that there are other factors. So people should not just say, asikwazi unifumana usebe lezempilo okanye onompilo asikwazanga ubafumana, whereas it was not because ebengekho or did not want to service. It was a question of people could not access because of other things. Yeah. But the second one is also coming to the viewers and anyone else who also happens to be a health activist, to say there are these issues as well that we need to, all of us, find a way of attending to or addressing. And I was happy when you were mentioning the example of the water issue, that how the response was there. Obviously, from a government point of view, it needed Tshwane municipality to come in. It needed the Department of Water and Sanitation to come in. At some stage, the Department of Human... Yes.
There was typhoid and cholera issues there.
So when it presented itself, it was a health issue.
Yes.
However, as we are saying, there were social determinants that were influencing that space. So I think that's another lesson to our viewers. I see Tikizwa here is saying, for me, there is still a gap between the haves and the have-not. That is an example of, e.g., informal settlements and urban areas, especially when it comes to the issues of water infrastructure that is not repaired. And it's as if I knew that she was gonna, I was gonna read something on water. Thank you very much, Tikizwa. And it's exactly what we're saying, that everyone would have seen. It was all over the media, and it probably would have made world news. The issue of Hammanskraal, and that was a reflection of what you are also raising, that the issues of water infrastructure have got a direct bearing on the health outcomes, basically.
Yes, in fact, so that we're not accused of only talking about the Eastern Cape. Yes, you're right. This is Gauteng now.
Yes.
The richest province in the country. So Gauteng, Hammanskraal specifically, the problem has been the fact that at a local government level, they had commissioned certain service providers to actually improve and extend the water treatment facilities. But there was this one particular one where the work was not completed. And it happens to be the one that
Led to this whole
provides the
thing.
water to Hammanskraal. And so the people of Hammanskraal are still to date having challenges of drinking water that is contaminated. And the root cause of that had to do with, I would say, I hope you won't be sued here, but it was corrupt practices at local government level, whereby certain service providers who did not have the competencies to actually deliver on these water treatment plants, and they were given money. And they went and chowed the money, but the work was not finished. So many years later now, the local government has to find resources to go and complete the work that was done shabbily before. So this is now where we talk about systemic failures.
Okay.
Systemic failures across the three levels of government may create a situation whereby a resource like water, clean drinking water, cannot be provided to the people. And that then influences the outcomes and the kind of illnesses that those people are exposed to.
In actual fact, I wanted to come in there, not from me.
Yes.
Liesel is saying this is such an important topic. It requires honest, robust, and continuous advocacy, which is the part we started with about advocacy.
Yes.
Human rights are not negotiable.
Yes.
And the discussions should be ongoing beyond this Human Rights Month.
Yes.
And thank you very much, Liesel, for that. And when we started, you did say, humbly so, that one of the reasons why you jumped when I requested your time was the fact that it's where we need to improve in terms of advocacy for healthcare services. And I think that's exactly what Liesel is also emphasizing, that it should be ongoing. And thank you very much for the comments as well, that it should go beyond the Human Rights Month, so that at least there is many voices that advocate.
The
it's
rights
not just
to
the
health are
yes.
not just for 1 month, it's 365. Now, Liesel is a colleague of ours.
All right, thank you.
She's a colleague of ours. She's a clinical psychologist, and I'm sure she won't be happy with us if, as we talk about issues of right to health, we don't touch on matters of mental health.
You know your audience and colleagues very much, because Liesel furthermore says that the right to access mental health should also receive urgent attention and not just focus on access to physical health care.
I know, because she's very, very passionate. Rightly so. She's very passionate about
we
matters
appreciate
of mental health.
Yes.
So we've been just talking about health that affect health broadly. There's also issues, people just because of LGBTQIA, are not made to feel comfortable to access to their detriment.
Yes.
Because there's still a lot of stigma in society about people, who are in that vulnerable group of LGBTQIA. That's just another example.
Yes,
discrimination on the basis of sexual orientation. Sometimes it's actually, and these are the things that come from the Human Rights Commission. Sometimes it's pure abuse and neglect. And here I think this is where I'll bring in the Liesel part. And Doc, I always have to say, I hope I don't put you into trouble, but 2016 in South Africa, we cannot forget the Life Esidimeni situation.
Yes, that's
because
correct.
It is a good example of showing how there could be abuse and neglect, which may lead to people actually having their rights violated. We lost 144 compatriots in a poorly planned, poorly executed deinstitutionalization kind of program by Gauteng.
And besides, that's not your words. That's from a report.
That's from a report.
That's from the Health Ombudsman report.
If we really want to talk health, this is just another example whereby 144 South Africans who were mental health users were discharged to poorly evaluated NGOs. Others didn't have the capacity. The end result is that those people died. And so it falls within abuse and neglect. And 10 years later, which is 2026, we should be reflecting and saying, how far have we come in terms of ensuring that the rights, mental health rights of South Africans are actually given priority. Even worse, because generally, as you know, in the public health system, or even in the private health system, there is bias towards physical health. If you look at your medical aid benefits, doc, I'm assuming you've got a medical aid.
I'm a public servant.
Yes, so if we look at your benefits, there's very little that is allocated to mental health. Just 21 days in a mental health hospital, or I think about 16 counseling sessions, and your money is finished.
So you're already donating Lizel to be a guest on our show when we're talking mental health issues.
Well, she can come in. She's very appropriate for that. So I think, because I was just going systematically on the violations as reported by the South African Human Rights Commission, to say there's violation at many levels: abuse and neglect, discrimination, medical xenophobia, and also systemic failures.
Yeah.
These are documented
outcomes
things from the Human Rights Commission. So, and obviously for them to visit our home province, it means some of these issues still need to be attended to.
Just on that note of the home province, and please, our fellow citizens of Eastern Cape, it so happens that it's not us who are having narratives to refer to Eastern Cape. And it's not only the blurry and gloomy ones. Cikizwa is saying here there are best practices indeed, specifically after the introduction of Ideal Facility Program. And thanks to the Eastern Cape Department of Health for beefing up staff through the project that appointed clinical staff on contracts. Otherwise, the shortage of staff was a violation in itself. And I think this is talking to both the issues of systemic issues that you spoke about. Yes. So I think there is an acknowledgement that as much as there are these systemic failures, but in terms of the intention, maybe for a lack of a better word, of making sure that there is access and there is outcomes. But I also wanted to link your comment on the issues of the mental health example you made.
Yes.
That it also resonates to your initial comment of saying access is not only about getting into the facility.
Yes.
Because if you look at that particular incident and that example, those people were within the health space.
Yes.
And look at what happened thereafter.
Yes.
So like you're saying, the protection of access when it comes to healthcare, it's not only about there is a facility, there is a building, therefore there is access.
Yes.
No, it goes beyond that.
Yes.
It's about the outcome. Yes. It's about offering the service itself.
Yes.
Okay.
Just something, Doc, and this one, I'm going to bring it back to you. So, okay. By Dr. B. He's the chief director on human rights.
Human resources for health.
Human resources for health, HRH. All right. He sits KwaNdlungu, National Department of Health, and he plans with his colleagues issues of deploying resources, doctors, nurses, and all of that. Now, Doc, there's a matter that we don't talk enough about.
Yes.
The issue of the competency of management at institution level. Because again, you can have the doctors and the nurses, but how those doctors and the nurses and the psychologists and the social workers are used for the benefit of people. If you've got poor leadership and poor management, then you may not get the desired outcomes. So under systemic failures, the issue of poor leadership and management, but by the way, this is not only at institutional level.
Yeah, of course.
Even
levels.
Obvious, remember, most the competency of delivery of healthcare, it's at provincial level.
Yeah.
So within provinces, sometimes we do see people who really could not even manage a spaza, but they are actually supposed to be planning for the province. So I'm asking you, now this is maybe from your official title, what are plans, or are there any plans to try and ensure that the appointments are actually linked to competence? We've just heard in the Free State some criminal person was appointed as a CEO of a hospital, So are there measures in place to try and ensure that at least this systemic issue is within your competency, to ensure that you appoint the right people for the right jobs so that they can do the right thing?
The reason I was laughing is that last week when we were saying this month we'll be looking at human rights and especially the impact when it comes to health issues, we then invited, because some of the viewers that we come across, we know some of them are leadership of the unions, especially frequently the leadership of DINOSA.
Yes.
So we're saying that as part of the topics for this month, the last topic will be looking at where does it put the healthcare worker? This issue of rights,
yes.
and I was laughing because that now empowers them on that day when they come for the topic to say, as the healthcare workers, our challenge is leadership. Yes. It compromises our rights and all that. So, but that's to share with the audience that indeed, in terms of the themes of this month and the topics, we would be also paying focus and attention, and maybe supporting the healthcare workers as well to say, what is it that you would like to bring to the table? How is your experience? What are the areas of improvement? But also directly speaking to what you have mentioned, that obviously there is always and the advantage for me, as much as you were, it's a bit on the spot in terms of the workspace I'm in.
Yeah.
But fortunately, the minister is a vocal person.
Yes.
And he always doesn't
Very
hold back the
responsive.
punch. Yes, exactly. So even what I might say, it's something that people might have already heard from one of his utterances in terms of the media space. He is very clear in terms of the building blocks of the healthcare system.
Yes.
And amongst those, one of the key areas he speaks about is the issue of leadership as well as the workforce. So there is an intentional attention that has been given to issues that talk to the quality of leadership so that is one thing that I can safely say, as much as we are here in Dr. B Talks, not as Department of Health, let's share that disclaimer.
Yes.
But obviously it's something that is in the public domain, that he is very intentional. If anyone has come across any of his session, he would not start the session without explaining and outlining the 6 building blocks. And key to that is the leadership and the human resource for health, in terms of the pillars that are important to him, as well as obviously the issues of financing. But the other issue I wanted to bring, even the example that you've made mention of, I think yourself, you have also shared with the audience that there is also this issue of the competencies that are being at provincial and so there is always that issue that comes into play, that let's empower, let's encourage, and let's support that in terms of those that have got access, they've got opportunities to advocate. There is no need to wait for the national level or to wait and say, let's have access to people who are kontlunkulu. Let's encourage the advocacy, especially when it comes to issues of access to health, issues of human rights, issues of healthcare rights, both physical as well as mental, and make sure that people can use the platforms that, or where they are, to ensure that this can be an improvement. And I think one of the issues that I see we're running out of time, and it was still enjoyable. We have got 8 minutes left, but we'll try and make time and respond to some of the issues. I was trying to check if there's any other comments from our viewers, and I do see some thumbs up and hearts acknowledging the topic at hand, and thank you very much for that. At least we do not have anyone that is still outstanding. But as we are wrapping up, please share with us what your parting words are when it comes to the topic of, I know you've got a big appetite because you are passionate about the topic, and I also know that you shared with me, if you don't mind, that last week you had to be in a bit of a personal space, emotional space, which related to the issue of access to care.
Yes, I think people need to also know, and maybe this is a very good example. So, the issue, March 12th, all right, on Thursday last week, all right, March 12th was World Kidney Day. All right, it's a day wherein across the world we focus on how do you preserve the health of those 2 bean-shaped organs in your loins that are supposed to help you to excrete, stuff that your body doesn't want, manage, your fluid levels in the body and all other things, So there is a situation, and obviously I won't be using names, but in the public health system, which services 84% of South Africans, when it comes to people whose kidneys have reached a point whereby they can no longer work, a person can only survive by undergoing dialysis, which is really artificial machines that try to do the work of the kidneys.
Yeah.
And that is done up until that person can get
Transplant.
a donor kidney, what we call a transplant. Now, because the number of people who need dialysis to be kept alive is so much higher than the available dialysis machines, the government, public health, has had to do what is called rationing. That is, decide who must
Criteria.
be given access to a dialysis for them to live and who can't. All right? So basically, the doctors must play God. Who must get access to the dialysis and who must not. All right? And so obviously, with all of the rights that we have, right to health and right to life, that was challenged, Uguti. But you say it's healthcare for all, Yet when we now have a family member who requires this service, you guys are telling us, but no, this person, according to the criteria, they can't access. So if a person is not a candidate for getting transplant, then that person can be excluded from dialysis. That is the issue. So that was challenged in 1997.
The case of the Durban issue.
Yes, Subramuni
Yes, the Durban case, yes.
versus the Minister of Health.
Yes.
So last week, a close friend of mine who had had a dialysis, who had dialysis and had a transplant, 10 years later, the kidneys had stopped functioning, the one that was transplanted. Now that person went back to the system, all right, so that they can be kept alive with a dialysis machine. But they could not be accepted at one of the big academic hospitals because they were no longer candidates
Criteria.
for transplant. So maybe the point I'm trying to make, there are sometimes legal constraints, constitutional law constraints that limit the right of a person from fully enjoying their health rights. In the Constitution, there's something called Section 36, which says whilst everyone has got right to, access all of these rights, Bill of Rights, but they can be limited. There could be limitations in the very rights if the reason for limitation is justifiable and is legal. So in this case, it was tested in 1997. The government was found to be, reasonable because there's not enough of these machines. But I thought it's something that we must understand, that there are times where you can't exercise your health rights, and you can't say they are being violated because the reason for you not to access that is covered within the limitation of your rights because the decision behind that is rational and it's justifiable. So I just thought the closing point maybe is that as we look through the 32 years, there was a song by Letambulu and the husband that said, it's not yet Uhuru. So if we're looking in terms of access to healthcare, rights to healthcare for all, it is not yet Uhuru. And the answers are not only from the Department of Health, it is the whole of government. That's the word I was looking for. Whole of government. Different departments working together
as
to
one
solve
government.
These issues of access to healthcare.
Thank you very much. I think it's either Usia Mtanda was reading your closing remarks because she's also put in to say, interesting topic, doctors. Sadly, there are systemic and environmental issues that are a violation of basic human rights, also adversely affecting or contributing to these social determinants of health. It then becomes these social determinants that contribute majorly to the country's mortality and morbidity rates, even beyond just access to healthcare system, which was your closing line, she says, which need to be addressed at structures beyond the health department.
Indeed.
And I think that becomes a very instrumental or even relevant way for us to be looking towards. I see that our viewers are still engaging, and I hope we are going beyond the time because of the two.
We can do another 15 minutes.
All right, I see that Kaise is saying as well that interesting topic, especially the issue of access versus what happens after access. Mostly, they are not happy. In the, again as well, Ciswa says, in the Supreme Court, or the case that we were referring to, it was ruled out that it is not emergency but chronic, so they cannot be provided the service. So it's what you are actually reflecting to say, there are also these legal and justifiable, acceptable issues now that affect the access as well.
So under medical ethics, rationing of limited resources is an acceptable ethical issue. So in the Subramuni case versus the Minister of Health, it boiled down to the fact that at the time there were only about 49 centers throughout the country in the public health system that could do kidney dialysis. Whilst in the private sector, they had about 429. This is 1997. So you can see that the demand was outstripping supply. And so at some point, there must be some criteria to say, who do we put first? Do we put a 35-year-old who doesn't have any other health challenges? Or do we put a 70-year-old person who has got uncontrollable diabetes that has already damaged other organs? So we are forced by the situation to play God.
Yes, no, thank you very much, and let's take this opportunity to thank yourself.
The producers are saying,
there is also
got an extra 15 to 30.
All right.
So maybe let's indulge.
I see as well that there is a comment that has come in now from Lubabalo Mashikane, who says interesting discussions, particularly because only 16% of South Africans have medical aids, as you had initially stated, which also the rest of the 84% depends solely on the public health sector, and discussions such as this one are crucial. So I think as much as you might have started and trying to wear gloves for me as my other cap is a public servant, I think there is an appreciation from the audience to say,
yes,
we need these conversations to be out there. Yes. And not only that, I also saw that, thank you very much, Doc, we have learned a lot from you. Keep up the good work. So that's what we want to achieve, by the way, in terms of Dr. B Talks. Hence, we could come and request you to come and be part of this. Because ours is to ensure that we empower, we educate, and make sure that people get to be equipped to handle health-related issues. And it's also trying to assist even our colleagues. We are exposed to colleagues that are doing their best, dedicated, and want to render the services to the best of their knowledge. So sometimes we need to also advocate and be their voice to say, these are the limitations and restrictions that they also undergo. Notwithstanding that, we also might have those colleagues that are also become an embarrassment to some of the professions, and that will come and talk to about in some other time. So the issue of access for us, it was trying to raise the awareness to say, we are mindful that there is a human rights element and we should be able to uphold that. But equally so, we were trying to ensure and remind people that there are other barriers that influence the issue of health access. And some of them, as we had outlined, do not necessarily depend purely or squarely on health as a department, but also officials as well as practitioners that are practicing the healthcare system. But lastly, it's for us to come and raise and remind that we can do more together. So if each and every one of us is able to advocate, as it was raised earlier on, and try and talk about these things. No, I'm not there. I know what you're trying to do. No, I am not there. It just came out.
I have not said anything. He's saying together we can do more. I'm sure you can recognize where that slogan comes from. song.
No, we're not there. We're not there. It just came out. It just came out. So, yeah. So, thank you very much. And let's also remind people to follow us. And please let me also give you a chance. You have a page. You have thingy as well as a handle on YouTube.
Yeah.
So. People shall share.
Yes.
No,
No, that's fine, Doc.
Yeah.
Look, it was a pleasure, or it is a pleasure, to just, it's one thing to be doing a show whereby you are sitting in your home, you are looking into your computer, I'm doing the same. Here today, we are actually engaging eyeball to eyeball. Okay, we've got glasses. So
there's four.
There's four.
Four eyes.
we are engaging on these very important matters. And so for me, I think I must thank you because, whilst we are streaming on your page,
yes,
we also streaming on
beautiful,
my page.
Beautiful.
And the issue is about collaboration. Not competition.
Yes,
and I think it's important, there's certain things you have as strengths, there are certain things I have as strengths, and we put together and achieve the common, mission, which is to educate and empower South Africans. Because empowered, educated, South Africans will ensure that those who are in levels of authority are able to be held accountable for their areas of responsibility. Because all of us, at the end of the day, we said Rome was not built in one day, but at least there must be progress that people can be able to see over a period of time. So, yes, I'm a public health advocate with my own channels. I'm on Facebook as Dr. Fundi Lenyati. I'm also on YouTube as Dr. Fundi Lenyati or Dr. Fundi. And also, I have a podcast that is called Health Matters, which again, it's just another platform of discussing anything that is health related. So I'm quite active. On TikTok as well, I'm available, but I've been a bit lazy there. So, but it's gonna be revived. So look, they must, those who've been following me, they must follow Dr. B, but also, when I do put posters to say I've got this conversation or that conversation, I expect them to do the same. Yeah. So thank you very much for your generosity of time. And also just allowing me to be on your platform, and I'll continue to do the same for you in my platforms.
No, thank you very much. You're going to bring the other side of me, which is an emotional, teary side of me. Just last week, we had announced on the Dr. B Talks that we have just secured a relationship and a partnership with Sowetan.
That's all.
And that's why I'm saying you are bringing out the teary side and the emotional side of me now that... you see, sometimes when we do things ngokuzinikela singakhange sibe kanti silindele nto uThixo uyakwazi umvuza umuntu, and that's what we are seeing at play. And we are really grateful that at least we are able to have a common ground in terms of collaboration and seeing each other as an opportunity for us to support and build each other. No.
I must say to the viewers, those who don't know, Dr. B Ludodana, Methodist Church, active gentleman who wears the red, what do you call that thing?
Underpatch.
Red underpatchy, So before today, he had to go to church and also to ask God to give him wisdom and ensure that the technology doesn't fail in our quest to empower the people. Thank you very much, Dr. P.
No, thank you very much. Thank you very much to the viewers at home, and continue to follow us on Dr. B Talks as well as Luvio Paeni. Please continue to invite as many people as you can, and also don't forget to drop your comments on the comment section. We'll make every effort to get back to you. And please share the video, share the link. I know on my Facebook page it will still be available, and also now you've just heard that we have gotten access to the YouTube page as well as the podcast page. So please make sure that you share as many as you can. Ours is to make sure that we empower, we educate, as well as equip our citizens, especially those that have got an interest when it comes to health activism and health issues. So yes, thank you very much. And that brings us to the end of the show for today. And please, I sincerely apologize for the 9 minutes. You know, I always say I respect your time. So when I ask you for 1800 to 1900 and you do that, I always appreciate that you've made time for me and to make sure that you grow the platform. So apologies that we had gone 9 minutes beyond. It is now exactly 1910, and we do appreciate that you have stayed in until this time. And please, let's meet and tune in next week. We are continuing with a theme under the human rights, and next week we'll be looking at your complaints management system. And I'm sure all of you already have issues to raise. So even during the week, you can start dropping your comments and your issues that you feel we may need to touch on when dealing with complaints management system, especially within the healthcare system and the healthcare facilities. So thank you very much. Stay tuned into Dr. B Talks and follow us and share as much. Next time, same time, same place. And Begeli Beki will see you on Sunday. Thank you.
Thank you very much.